If the patient is having a history of cough, sputum production is there, there is a dyspnea, there is a smoking history, or there is a exposure to the biomass fuel, you will have a diagnosis of COPD in your mind. If the chest is barrel shaped and on auscultation, we may find that there will be sometimes there will be no wheeze, only that there will be a decreased air entry bilaterally will be there, and the patient will not have a wheeze. So that will also go in favor of the COPD. If the patient is giving a history of family history or the drug history, then that should be taken into account. Now the general examination, the patient will be breathlessness on exertion. He will have a diaphoresis. He will be lean and thin. I told you that about that there will be an increase in the respiratory activities. He will be anxious and the speech will be interrupted by the breath, and he will have a pursed lip breathing, because this pursed lip breathing will help in the uh, breathing process of the patient. So he will try to have a pursed lip breathing. So what you will see that he will be a tachypneic, he will be a tachycardia will be there. In early stage of disease, chest examination may be normal. However, in the advanced stage, he will have a barrel-shaped chest, he will have a prolonged expiration. These may be there, sometimes these may not be there. There will be a use of the accessory muscle of respiration will be in use. It will be working. The JVP will be distended in if the patient is in failure. Peripheral pitting edema will be there in failure. Tender hepatomegaly will be there, and signs of pulmonary arterial hypertension or the carbonyl will be there. Very important about the chest X-ray, the diaphragm will be low and flat. The diaphragm will be low and flat. Diaphragm will be there because of the hyperinflation of the lungs. There will be, as if you go for a lateral X-ray, there will be a subchannel air trapping will be there. Bulla or bullous will be there. What do you have a difference in the bulla and the bullous? That bulla will have a hairline, arcuate line will be there, an area of hypertranslucency demarcated by a thin arcuate line will be a bulla. And if we don't have a thin arcuate line that is surrounding a hypertranslucent area, that is a bullous area. So it is a difference between the two, bulla and the bullous. These are not two similar plural or singular terms. The disease entity is different. In bulla, you will be able to trace a thin arcuate line and the area of hypertranslucency will be there. But in the bullous area, you will find only the hypertranslucency will be there, and the hairline arcuate line will be absent. The prominent bronchovascular markings will be present. There may be an increased hematocrit in the cases of chronic hypoxia. In the If the patient is admitted with you in the ICU, in the early stage, you may have a respiratory alkalosis will be there, and in the severe cases, when you need a mechanical ventilation, invasive ventilation, the patient may go into the respiratory acidosis. So the spirometry should be done. the FEV1 and the FVC ratio is less than 0.7, and the post bronchodilation will be useful, and the reversibility will be partial in such kind of patient. We will not have the reversibility as we see in the patient of bronchial asthma. If there is a reversibility and the patient is having a history of smoking, that will be considered as a asthma. COPD overlap syndrome will be there. So it is clear by now that we have taken the history of the patient, we have done the X-ray of the patient. One more thing, in the chest X-ray, we will find a heart to be a tubular heart. A heart will be a tubular heart will be there, or a floating heart will be there. The diameter of the heart will be, if it is less than 10 centimeter, then we call it as a narrow heart, will be typical seen in the emphysema patient. So by the spirometry, we will assess the airflow obstruction, then we'll assess the symptom and the risk. So we have graded that whenever the FE1 FEC ratio is less than 0.7, it is a case of obstruction. In the gold one, if it is equal to 80 or more than 80, then gold 1. If it is the FE1 is between 50 to 79, it is gold 2. If it is between 30 to 49, it is gold 3. And in the gold 4, we have the FE1 of less than 30%. Now, earlier they used to have a different classification A B C D के यूज करते थे. अब 3 क्लासिफिकेशन हो गए, E, A और B. सबके सामने आप देखिए, E के लेफ्ट हैंड साइड में आप देखिए, यहाँ इसमें एक्सेसरबेशन की हिस्ट्री लिखी हुई है. If the exacerbation are more than two moderate exacerbations are there, or any one exacerbation leading to the hospitalization, then will be classified as E. और A में लिखा हुआ है 0 or 1 moderate exacerbation to the hospitalization. And in B, we have a MMRC of 0 to 1 and the CAT score is less than 10. And in B, we have a CAT score of 10 and the MMRC of more than 2. So this is very important in the diagnosis, and in the treatment part, this classification will be very important. Please take a screenshot of all these things. This is very important in the management of COPD, E, A and B. That will be helpful in the categorizing the patient of COPD.